Thank you everyone again for joining us today. We're going to be talking about easing the burden of COVID on the healthcare system using an IWMS. Today we have with us Will Indramalos. He is a program manager who is focused on enterprise asset management at New York Presbyterian Hospital. And we also have Nick Stefanidakis, who is the VP of Field Sales and Enablement for Archibus Ceraview. So thank you both, Will and Nick, for joining us today. And with that, I'm going to turn it over to Nick to kick us off.
Great. Thank you, Danielle. And thank you, everybody, for attending. So at Archibus and Ceraview, we've been holding a lot of webinars recently, mostly focused on the corporate occupier and topics such as transitioning to remote work, ensuring that staff have the tools that they need to be productive as they're working remotely, determining how we're going to manage, maintain, and clean the facilities, and planning for things like a safe return to work for people. How are we going to bring people back into the office? Where are people going to sit? How are we going to maintain physical distancing? All of those things that we've heard so much about in recent times on the news and in work every day. And then finally, executing those plans and putting in programs to monitor and ensure the continued safety as we work more and more towards normal, or whatever the new normal might be. This week at Archibus and Ceraview, we've shifted gears a bit and have been talking more about specific industries such as education, government, and as you know, today we'll be speaking about healthcare and how organizations and the frontline workers are reacting to meet the increased demands of these unprecedented times. In particular, how are hospitals managing the increased capacity demands? There's really, as it says here, an unprecedented need for finding solutions, creative solutions to manage the surge in capacity that we're seeing for everything from medical screening, triage, and ultimately the patient care. And the curve that's shown on the screen here from the WHO is a little bit different than the curve that we were showing in terms of corporate back to work strategies. So right now we're sort of somewhere in the middle of this, coming back into the transition phase. And how have organizations, healthcare organizations, managed through this process? Next slide, please. So we've seen a lot, again, in the news about different types of pop-up hospitals or pop-up patient care sites being assembled in really record times, whether it's the Army Corps of Engineers or just local folks coming together to assemble and convert different types of venues such as convention centers, sports venues, even as it's pictured here, Central Park in New York City, where they built a pop-up hospital to deal with overflow capacity. And you know, how has that been used? All of the safe practices around building those kinds of facilities. Today, we're really going to focus more on within the hospital itself and finding that additional capacity within the hospitals themselves, as opposed to focusing on the moving patients out to these surge capacity type sites, the pop-up sites. Next slide, please. Many organizations, industry organizations such as ASHI, Facility Guidelines Institute, the Department of Health and Human Services, and really many private organizations have begun to jump into action and provide leadership and recommendations for accommodating the needs in the middle of this crisis. And we've seen a lot of this both in corporate, higher education, healthcare. So different organizations like we're showing here, ASHI coming out with a series, and this is just a subset, but coming up with their COVID-19 advisory and making recommendations for how to plan and manage. So things like reviewing patient entrance and flow patterns throughout the facility, evaluating accuracy of space pressure relationships. So understanding positive pressure rooms, negative pressure rooms, reviewing emergency management plans, especially in relation to surge capacity issues, security plans, contingency plans for possible occurrence in which demand for isolation rooms exceeds the available capacity. So lots and lots of recommendations like this are coming at us from all over. In addition to ASHE, we've seen other recommendations or checklists, such as the one shown here from the Department of Health and Human Services. They've come out with a series of planning checklists. This is an excerpt from their healthcare planning checklist, and it's actually really quite extensive. This is just one small section of it. As you can see, it's jumping around a little bit, section 3 all the way down to 3.37, and there's more sections above and below this and in other industry-specific types of checklists. So much coming at us for how to manage in these crises and how we're going to find that extra capacity and do it in a safe way and make sure that we're not putting the staff or the patients in any undue risk. Next slide. One model that I particularly liked is this model that was kind of a hierarchy of needs, starting with, and this was more of from the private sector. I think it was Array Advisors. They start with estimating the demand. So looking at the available resources to understand predictive models and understanding what the capacity needs might be, the surge capacity. And then as the time goes on and as the surge increases, how do we deal with the various phases or tiers, as it says here? So, from the very beginning, in tier 1, defining elective surgeries and canceling those cases, determining ability to convert former semi-private rooms back to double occupancy, identifying ambulatory surgical centers, endo centers in your region that can potentially manage extra capacity, so you can move some of those services. Identifying strategies for patient segregation and isolation, reviewing mass triage approaches and plans. And then as demand increases, moving up the list to things like enabling full capacity protocols, determining feasibility of converting modern private rooms to double occupancy, assessing capacity of preparatory recovery spaces, alternate surgical recovery operational plans, redirecting additional outpatient surgical cases to those ambulatory surgical centers. And then at the top, relocating hospital-based surgical and post-surgical services, creating OB delivery space outside of the hospital, converting operating rooms to additional ICUs. So really it's just this, as you get more and more demand, what are the steps that are recommended to take to identify and leverage existing capacity to accommodate more of the needs coming in based on the COVID increases. And then some of the required resources and support functions, making sure that there's adequate documentation, PPE for patients and staff. Again, negative air pressure conversions to make sure that there's infectious disease controls in place. As you add capacity, do we have enough beds in the market to populate the spaces that we might be identifying and so on? So all this kind of leads to our guest of honor, Will Andromoulos, who's going to talk to us about how one particular hospital, New York Presbyterian Hospital System in New York City, has managed through this process. And with that, I'm going to hand it over to Will, and Will's going to take it over. Thank you, Will.
Oh, good morning. Thanks for letting me join you. Interesting. I had not seen that slide before. And it's funny, the stages, the tiers 1, 2, and 3, we probably went through that in the first week and jumped right up to there. So this is the type of intensity that we experienced throughout the COVID crisis. And mind you, it's not over yet. Obviously, I'm with New York Presbyterian Hospital. We are the largest hospital system in New York City. We are rated the #1 hospital in New York. We are also rated up in the top 5 of hospital systems in the United States. And we were also the epicenter of this virus. So there was a lot that happened very, very quickly. And as I said, all of the things that you saw on the tier diagram basically happened in those steps. Now, mind you, I'm a program manager for enterprise asset management systems. I've got a team of professionals working for me, and we maintain system standards, data standards, space planning with Archibus, lease administration, regulatory compliance applications, drawing management, you name it, including asset and work management throughout the enterprise. We're a hospital system of about 11 different campuses throughout the metropolitan area, 15.5 million square feet of space under management, and about 44,000 employees. So we, as everyone knows, we got hit pretty good in the New York metro area, New York, Connecticut, New Jersey, and we had to move quickly. Where my team came in is supporting our facilities operations and real estate unit. They were tasked with looking at our existing inventory and being able to look at what can we do to increase capacity and do it quickly and safely. Looking at inventory of intensive care units, pediatric units, behavioral units, operating rooms, procedure and recovery rooms. We were tasked with building out 2 field hospitals. And interesting, what it comes down to is your asset inventory, your space inventory, and the accuracy of that. Fortunately, we have Archibus in place for a number of years. We had established a real tight set of standards, primarily industry standards on room classifications and coding. And through our data warehouse and dashboard reporting, we were able to quickly be able to show what the existing capacities were, and more importantly, to look at where we could expand upon those. One of the tiers mentioned too is that one of the first things we did was suspend elective surgeries. And what that did for various reasons, but also opened up a number of operating rooms. So operating rooms were converted into intensive care units. Temporarily, mind you, because they've actually gone back. And what we were able to do through this exercise was more than double our capacity for treating patients. Some of the interesting things were behavioral units, and we have behavioral units at several of the campuses. We were able to shift those all to a behavioral health center, those patients, and go back, and rooms that you would not think could be converted were converted into intensive care units. Medical gas run, utilities run, temporarily, mind you. And as we undo these spaces and we go back to what is a new normal, and we'll never go back to baseline, mind you, is that looking at how we can look to use these spaces again in the future. So rather than doing this here, that we know what spaces are available and what are suitable for conversion in this case. We also had the luxury of one of our newer buildings that went up a couple of years ago is building information modeling, tied directly through a connector to Archibus. So all of our drawings, room inventories, all the attributes, everything necessary to do planning are all available through Archibus. And one of the interesting things about that building is it's an ambulatory care facility, and we were able to rapidly and easily convert 3 floors of procedure and recovery rooms to handle severe cases of COVID, people that would be intubated. And it come down to being able to pull up things in the model to be able to show what were the pipe sizes, what were the capacities, and that would be able to tell you the capacity of the number of patients that you could cover on those floors. Could be a quite difficult task otherwise, but because of having the model actively connected to Archibus and having those capabilities, which are still developing, mind you, it was relatively easy to be able to determine how we could increase capacity in that particular building. As I said, we were able to basically double our capacity for treating patients by doing temporary conversions, doing permanent conversions, looking at our inventory of 1-bedrooms and 2-bedrooms. They could be converted to negative pressure relationships, either through modifying parameters in the building automation system, or in the case of some of the older buildings, actually bringing in ventilating and units with HEPA filtration on them and converting those temporarily into negative pressure rooms. So it's been quite an experience. Like I said, we built several field hospitals. One of them happened to be an athletic facility that was covered in a bubble, and it happened to be right next to one of our major hospital sites. So we were able to move quickly. It was actually, the facility was owned by Columbia University. So we worked with them, converted that into a field hospital. Although it didn't necessarily need to be filled to capacity, but it was there because we did not know how bad this was going to get. We also built another field hospital down at our other major campus. Same thing, it was to be able to support the emergency department. And all in all, we made it through the peak, which hit us in New York about the second week in April. Things were growing quite geometrically at that point in time in patients, and it was quite serious, mind you. So of the number of patients that came in, and there were thousands of them in our system, a large percentage of those people needed intensive care or needed ventilation. The numbers have dropped dramatically since that point in time. It's manageable. We still have a lot of safe practices in effect, and we've been able to start opening up some of the facilities back to elective surgery, reconvert back our operating rooms, for example, that were used for intensive care units back into their intended purposes. But some of the things we have learned through this is that it's a new normal. We're never going to go back to what it was. In fact, if there's a second wave, which we suspect there might be, or the next major event that happens in a few years, we have to be fully prepared and use everything we've learned through this experience to be able to move again through that. Like I said, we've learned a lot, rethinking how we use our spaces. So even though we've doubled capacity, some of those being temporarily, we will never go back to baseline. We will go back to somewhere in between. And this is where Archibus becomes very important, because Archibus today is primarily a snapshot of what your capacity is, what your room inventory is at this point in time, classified by categories, room types, room functions. What we found important is to continue building out Archibus and our inventory to be able to specify room pressure relationships, for example. And not only that, but what are that room's capabilities, so that when we go through, if we go through this exercise again, we know what we have ready and able to easily convert for these intended purposes. That was a very big thing. We've also started talking and looking at as far as our real estate needs too, because throughout this, hospitals traditionally don't do telecommuting. Like for myself and my entire team, which we never telecommuted before, is now on alternating days. It works well. We've determined, leadership has determined, although it's not necessarily as effective, but it's good. It does work. So you start to rethink about your workplaces and looking at, do we really need that much real estate? And how do we use that real estate? And going back to what Nick said earlier was that workplace planning becomes a greater focus. Hoteling, techniques such as that, we've never done that before. We have a major facility in Midtown Manhattan that we just built out a couple years ago. And believe it or not, we don't do any space planning with respect to that. This all of a sudden becomes quite important. And again, one of the big takeaways here is that technology and integrating technology, such as building information modeling. A lot of times before this, we were questioning the value in maintaining an active model and trying into this. I think what we've done is we've seen a number of good, solid use cases for building information modeling. The example being the medical gas supply system for the newer building. And it's kind of justified the approach to continue on going, keeping a model live, keeping it integrated with our workplace management system. And not only that, getting all of its capabilities into the hands of the directors, the supervisors, the managers, and even to the technicians. All of this information that can be at your fingertips. It's been a great learning experience. It's not over, mind you. We all know that. We see things happening in other parts of the country. It's still pretty significant here in New York. We are just starting to reopen the city. I believe we're at stage 2. So time will tell how that works out. But in any case, it's been quite an adventure, and we're ready to continue onward. So on that, I can open it up.
Thank you, Will. It looks like we do have a few questions that have come through.
Sure.
So the first one is, are you or how are you tracking assets such as equipment, PPE, sanitizer, etc.?
Our area is under facilities, operations, and real estate. So we track all of the assets we track are primarily spaces, of course, Archibus. We also track over 90,000 assets across the entire enterprise. They're all tracked in an enterprise asset management system that is linked to Archibus, called TMS by Accruent. That's where we do all of our, like I say, our asset management, as well as our inspection, testing, and maintenance programs. Now, our PPE and other types of materials are tracked in other systems, such as Lawson and our materials management systems outside of our area.
Okay, thank you. The next question is, what was the process for deciding which spaces could be converted to make more room for patients? And do you have a plan in place for further expansion as well if we do have a second wave?
Well, the decision was made looking at the inventory with leadership and the facilities operations management, and looking at the spaces and their capabilities. So I know I was part of one of the initial surveys to validate inventory. We were all divided up parts of the hospitals. I ended up taking on a hospital myself and going and confirming our inventory and making sure that Archibus was in fact the system of record. We looked at a number of things, such as some of the older buildings, and a good example was the behavioral unit that I mentioned. So there were areas where there was an entire floor of one of the major facilities. We were able to shift all of those people to patients to another facility and reopen that. Interesting to note is that since it's an older building from probably the 70s or 80s, a lot of the medical gas had been in the walls. It was just covered up. Didn't realize that it had existed and it was still viable. So they ran new lines, considering this to be a temporary space. But as they do, they've been thinking about, all right, these spaces have the capability now of being converted for surges. So it's important so that we know what the facilities are, what the capacities are, and when we, in the case of a behavioral unit, when we go and we cap things and cover them up, we know exactly where those facilities are so that if we should need to use them again, then they are available. One of the important things that we've learned from this is that it's not just what your facilities are being used for today, but its capabilities. So we know what we can do. We know, like I said, we don't want to go back to baseline. We want to know that if we have to, this is our capacity with selecting certain areas that can be easily converted, deployed to cover that. Others, it might take some more effort to do that. I hope that answered that.
Yeah, that was great. Thank you. It looks like we have a couple of questions actually related to BIM. So the first one is, you mentioned you guys are using BIM. Where do you see BIM's advantage relative to regular CAD?
That has always been a challenging question. We've struggled with for a number of years. Like I said, we have three major buildings online now, BIM. We have linked those directly to Archibus, so we are producing and publishing drawings that are available on Archibus Mobile, as well as in Web Central, and drawings that are published from the BIM model to PDFs that are available on portals, as well as our document management system, right down to the level of the technician available on their iPads. What we see the advantage, and it became very clear through this exercise, and thanks to some of the new technologies that we're using Autodesk Revit, of course, is that now through cloud storage and cloud management of your BIM model and using the BIM 360 tool, we're able to publish drawings. So where we would normally go to CAD drawings, PDFs for architectural, life safety, mechanical, electrical, plumbing schematics, and all of that, we see that this can all be just by published views right from the BIM model, available directly to the technicians. And it's easy to use too. In previous years, when we looked at some of the tools available, it would have been a big challenge. You would end up publishing to either CAD drawings and PDFs and getting them into the hands of the people who needed them. What we like to see here is that everything you need is at your fingertips. I know from this model being published, whether it's directly through BIM 360 to a tablet or through Archibus and being made available in that manner, that I can look at and isolate systems. I can determine the effects of if I need to shut something down, what downstream is affected by it, what kind of planning do I need to make, what kind of interim life safety measures do I need to take. Looking at individual assets, being able to find them, dampers, VAV boxes, you name it, can be easily found. And not only that, finding all of the properties and standards that were applied to it, and even furthermore, being able to link directly to OEM manuals and warranties, everything available really at your fingertips. And we're seeing that happen. There's a lot of work yet to come together to make this happen, but we're looking to prototype this approach with these three buildings. Okay?
Great. Thank you. And I think you touched on this a little bit here, but just in case you want to add anything else, the other question was, how detailed was your BIM data to begin with?
I think the level of detail, and Nick, you may remember this more than I do, I think we took it to either a 300 or a 400 level of detail.
I think it was 300.
Yeah, 300. So items would be close enough to find. And we weren't looking at nuts and bolts and fasteners, mind you, but enough detail for a facilities management model.
Great, thank you. We have just a few more questions that have come in. How are you using the technology to protect the staff? And I guess kind of related, that another question is, how do you communicate changes to staff?
That unfortunately would be out of the scope of what we do in my team. So other than knowing what the spaces are, what they're used for, and then that portion, like I said, would be outside of our area of facilities operations and more in line with operations itself.
Got it. Thank you. Okay, the next question is, are you using the data to report to FEMA for reimbursements related to, I think, the conversion to COVID?
Yeah, I think the question is to help manage, there's investments that the hospital had to make to convert. I think the question is related to, are you able to use the data to help in reporting to FEMA or any other organizations around reimbursements for those investments?
Exactly, in a number of manners, because not all the systems have been kept up to. Ideally, one would say that you'd be putting in work orders and projects, tracking labor, materials, outside vendor work directly to work orders based on work that was performed in spaces, and then output that. That didn't know. In reality, that didn't happen. There's some backfilling to go on, but obviously the big thing is tracking these costs and being able to report out for submittal for reimbursement to FEMA. There have been a number of things done based on metrics. So if we know we've converted a certain area of space, we know the square footage, of course that comes from the system. We know the labor hours that were dedicated to that from timekeeping, which is also integrated to our work management system. There are some work orders, there are some projects, but there are, more importantly, if we knew that we had a crew that was on a project to convert these spaces that are managed in Archibus, we can actually pull those costs together. And I think that's primarily the way we're doing it. In an ideal world, you would have had everything to work order. You could push a button, run a report, and be able to show exactly costs in the conversion plus the reconversion.
Great, thank you. Now it looks like the last question is, could you please share how the technology is helping you in managing the quarantine centers and isolation centers?
Again, going back to what our systems do. We're an integrated workplace management system, space management, asset inventory, so forth. But where reality comes in is there are other systems in the hospital that are managing spaces also. Those systems would be tracking exactly what that use is, the temporary uses, let's say. Archibus today, as we look at it, is showing what the spaces were prior to conversion. Those external systems would be managing what they are in use for today. What we will do is we will have to true those up when we're through this. One of the other interesting things to say is not all systems throughout rely on Archibus, which is our system of record for space information. We're making a great deal of progress in changing that. We have a new biomed application that's going in place. We have an existing IT and service ticket in place. Throughout this exercise, we've realized the value in a single source of information, and that will indeed be Archibus. So where we had looked at down the road as far as integrating these other systems, we see the value of this, and then we're accelerating that. Going back to the original question, that will help to make sure that the systems that clinical operations use, such as Epic and their room planning systems, their requisitioning systems, all rely on a single source of information, which we intend to be Archibus.
Great, thank you so much, Will. So now let's turn it back over to Nick to give us just a a quick update on what we have done to help a federal health customer.
Sure. Will, thank you very much. That was really insightful and really great to see how NYP was able to respond, and I think you said more than double the capacity of ICU rooms, beds to deal with the pandemic. Just a great story. Really appreciate you sharing that with us. So as Danielle mentioned, we had have a large federal health organization that is a longtime Archibus user, and we're able to, using their system, come up with ways to help them manage through some of the challenges that they had, because as their role in government and in the current crisis have staff that needs to be continue to work through this crisis, and are required to be on site to do their work, and so they needed to really have a system in place to help them manage the challenges. And in particular, some of those challenges were being able to identify and mitigate COVID-19 contamination. So whenever a employee reported sick or with symptoms, they needed a way to track that person and where that person works and who might need to be notified, what spaces were impacted so that they could safely quarantine those spaces for full decontamination, and then eventually bring those impacted spaces back online after the cases were resolved and the spaces were cleaned. And again, just to ensure the overall safety and protection of the staff and their contractors. In the solution, working together with ATEC, COVID-19 Tracker, which is a solution that was developed on Archibus using the standard system and Esri GIS system to identify globally all of the locations and the impact at each of the locations that they manage, the ability to track the locations, show the path of infection, easily identify the spaces that have been quarantined and the status of the decontamination efforts around those spaces, and to be able to, again, ensure that those spaces are safe, and when they reopen them, they have all of the tracking and the history of the cleaning records and so on, to ensure that they're following all of the proper protocols around cleaning and decontamination. And this will be an ongoing effort, not just as part of this immediate need, but going forward, this will be used throughout the system to help them manage going forward as the pandemic continues on, hopefully starts to wind down. But this was a really great solution that was developed using Archibus to help manage in this particular case.
Great, thank you, Nick.
Sure.
Just a couple of other things we wanted to make sure you are aware of. The first being our health and safety offer. We are offering free new licenses of our health and safety application through September 30th of next year. This offer is available to all existing Archibus customers with an active software subscription contract. It is available on any version of Archibus Web Central where the health and safety application is available, and it is subject to the same support as other Web Central applications. If you would like to get more information on this, you can go to info.archibus.com/EHS-offer. The other item is we have a Getting Back to Work resource center where we're posting everything related to COVID. We have a bunch of interviews, blog posts, on-demand webinars. This webinar will be posted there as well. So it's just a great resource for you guys if you want to check it out. That's at info.archibus.com back to work. And then finally, we have a brief survey. As soon as you close out of the webinar, a survey should pop up with just 3 questions. If you would just take a few minutes to answer those questions, we would really appreciate it. And that is all we have for today. So again, I want to thank Will. Thank you so much for joining us. It was really great. And Nick, of course, thank you for joining us as well. And thank you to everyone who attended. We hope that this was valuable.